Good day, everyone. Good day, Ms. Taloma. We are Group 5 and we will be talking about the malaria disease. In this presentation, we will be talking about its history, the etiology, modes of transmission of malaria, its vectors, its pathophysiology, the life cycle of Plasmodium, and its morphology, its differentiation, and the diagnosis and treatment of malaria. Um, so let's start off at history. In 5th century BC, Hippocrates first described the clinical picture of malaria and some complications of the disease. In 1880, Leveran first described the malaria parasites in blood films of man, which is the asexual stage of the Plasmodium falciparum. In 1897 to 1898, a group of scientists led by Ronald Ross discovered that mosquitoes, which is the genus Anopheles, were the vectors for transmitting malaria to human. In 1939, Paul Muller discovered the insecticidal properties of DDT, and it was widely used to control malaria endemic. In 1955, the WHO adopted the concept of malarial eradication, resulting to elimination of endemic malaria from Europe and Australia. In 1969, it was discovered that there is an emergence of drug-resistant strains of Plasmodium in Asia and in Latin America, and this is still persistent until right now. The etiology of malaria is caused by the infection of red blood cells with protozoan parasites of the genus Plasmodium, which is inoculated into the human host by a feeding female Anopheles mosquito. Malaria remains the leading parasitic disease that causes mortality worldwide. There are 5 human Plasmodium species transmitted from person to person. And these are Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Plasmodium knowlesi. This species, Plasmodium falciparum, is found in Africa. It's the most common type of malaria parasite and is responsible for the most malaria deaths worldwide, for it causes the severe malignant tertian malaria. The Plasmodium vivax, it is the predominant malarial parasite in most parts of the world, and this causes milder symptoms than Plasmodium falciparum. It causes the benign tertian malaria, but it can stay in the liver for 3 years, which can result in relapses. The Plasmodium ovale, it is fairly uncommon and found in West Africa, and it can remain in your liver for several years without producing symptoms. It shows the tertian fever. Plasmodium malariae is only found in Africa, and it shows the quartan fever. Plasmodium knowlesi is very rare and found in parts of Southeast Asia, and it shows the 24-hour fever paroxysms. Its etiology. The first symptoms of malaria are non-specific. They comprise headache, lassitude, fatigue, abdominal discomfort, and aches, usually followed by fever, chills, perspiration, anorexia, vomiting, and worsening malaise. In young children, malaria may also present with lethargy, poor feeding, and cough. Disease progression to severe malaria may take days, but can occur within a few hours. Severe malaria usually manifests with one or more of the following: a coma, metabolic acidosis, severe anemia, hypoglycemia, acute renal failure, or acute pulmonary edema. If these are left untreated, severe malaria is fatal in majority of cases. There are different kinds for modes of transmission for malaria. First is the mosquito-borne malaria, which is the most common type of transmission. It spreads when a mosquito becomes infected with the disease after biting an infected person. And the infected mosquito then bites a non-infected person. Then the malaria parasites enter the person's bloodstream and travel to the liver. And then when the parasites mature, they leave the liver and then infect the red blood cells. In transfusion-transmitted malaria, it happens when An accidental Plasmodium infection is caused by the whole blood or blood component transmission from a malaria-infected donor to a recipient. So, infected blood transfusions directly release malaria parasite in the recipients, which can cause high-risk complications and even death. Congenital malaria, this is rare, and it is when infected mothers transmit parasites to their child during pregnancy, before or during delivery. Needle sharing induced malaria, this is also rare, and this is through needle sharing among intravenous drug users. The vectors of malaria, um, um, the only vector of human malaria is the female Anopheles infected female Anopheles mosquito. There are about 430 species of Anopheles, but only 30 to 40 are actual vectors of malaria. The rest either bite humans infrequently, or they cannot sustain the development of malaria parasites. The Anopheles are found worldwide except Antarctica, and it is transmitted by different species in different, and it varies in different geographic regions, in different environment, and in different environment. For example, in different parts in Africa, the Anopheles gambiae complex is the chief vector in Africa, and in North America, it is the Anopheles freeborni. The area of distribution is also different. In foothill regions, you can see Anopheles fluviatilis and A. minimus. In the coastal regions, you can see A. stephensi and A. sundaicus. And in the plains, it is A. philippinensis and A. culicifacis are usually found there. A. stephensi are highly adaptable, and they are found to be the very potent vectors of human malaria. The Anopheles mosquito goes through 4 stages of their life cycle: egg, larva, pupa, and adult. The first 3 stages are aquatic, and the last in the last 7 to 14 days. And lasts 7 to 14 days. The adult Anopheles have slender body with 3 sections, which is the head, thorax, and abdomen. The male mosquitoes do not bite, so they cannot transmit malaria or other diseases. The female lays 30 to 150 eggs every 2 to 3 days and needs human blood to nourish these eggs. Thus, there is regular cycles of blood feeding and egg laying. Adult females are generally short-lived, with a small proportion living more than 10 days in tropical regions. Most are crepuscular or nocturnal, and they both feed indoors or outdoors. They start biting by late evening, and their peak of biting activities at midnight and early hours in the morning. They breed in natural water collections. That is why it is very advisable to remove any stagnant water in bottles, coconut shells, and tires. Uh, the Anopheles species is distinguished from other species by their palps, which are as long as their proboscis, presence of discrete blocks of black and white scales on the wings, and also, as you can see in this picture, their typical resting position. The Anopheles species, their abdomen sticks up in the air, while the Aedes, their abdomen is parallel to the skin of the host. The factors affecting the development of the malaria parasite in the mosquito from the gametocyte to sporozoite stage. These are ambient temperature and humidity. Higher temperatures accelerate the parasite growth in the mosquito, and the Anopheles survival allows the parasite to complete its cycle in the mosquito. The sporogonic or extrinsic cycle can be seen in the mosquitoes, and its duration there is 9 to 18 days. The other diseases transmitted by the Anopheles uh, uh, are Venturi bancrofti, the Timorese filaria, the Bruguiera timori, and several arboviruses. Uh, and now we will talk about the pathogenesis of the malaria. So in the pre-patent period, interval from sporozoa, which is the interval from sporozoite injection, the detection of parasites in the blood. In average, it takes 11 days to 4 weeks, and it depends on the species. In Plasmodium falciparum, it takes 11 days to 14 days. In Plasmodium vivax, 11 to 15 days. In Plasmodium ovale, 14 to 26 days. And in Plasmodium malariae, 3 to 4 weeks. Its incubation period, which is the time between sporozoite injection to the host and the appearance of the clinical symptoms, this is 8 to 40 days. And again, it also depends on the species. In Plasmodium falciparum, it is 8 to 15 days. In Plasmodium vivax, 12 to 20 days. In Plasmodium ovale, 11 to 16 days. And in Plasmodium malariae, 18 days. Incubation period. The incubation period may range from 9 days to 3 years, and it depends on the parasite strain, the dose of sporozoites inoculated, the immune status of the hosts, and the host's malarial chemoprophylaxis history. When traveling to a malarial endemic area, there is a risk of developing malaria up to 2 years and even longer upon leaving the area. That is why the CDC advises that you have to take your malarial vaccine 4 to 6 weeks before your departure, and because partial or incomplete prophylaxis may prolong the incubation period several weeks after termination of medication. There is no absolute clinical features of malaria except regular paroxysms of fever with associated asymptomatic intervals. The prodromal symptoms, feeling of weakness and exhaustion, desire to stretch and yawn, aching bones, limbs and back, loss of appetite, nausea and vomiting, sense of chilling, and at the onset, there may also be malaise, backache, diarrhea, and epigastric discomfort. There are 3 stages of malaria paroxysms. It is the cold stage, hot stage, and the sweating stage. In the cold stage, it starts with sudden inappropriate feeling of coldness and apprehension. The mild shivering turns to violent teeth chattering and shaking of the entire body, and this is caused by intense peripheral vasoconstriction. A patient may vomit, and febrile convulsions may ensue in young children. This can last 15 to 16 minutes, and then the hot stage begins. The hot stage, or the flush phase, the patient becomes hot. That's the name of the stage. It manifests with headache, palpitations, tachypnea, epigastric discomfort, thirst, nausea, and vomiting. The temperature may reach 41 degrees Celsius or more. The patient may become confused or delirious, and it will last from 2 to 6 hours. The sweating stage, or the effervescence or diaphoresis, ensues with the patient manifesting with profuse sweating. The temperature lowers over the next 2 to 4 hours and the symptoms diminish. The total duration of the typical attack is 8 to 12 hours. The classic periodicity of attacks develops only if the patient is left untreated until the time when the life cycle phases become synchronized and sufficient red blood cells containing schistons rupture at the same time.
Hi, this is Jeffrey Valenzuela, and I'll be taking over the report. So right now we're at recrudescence. Recrudescence is the renewal of parasitemia, or clinical features arising from persistent, undetectable asexual parasitemia in the absence of an exoerythrocytic cycle. This happens usually due to treatment failure or incomplete elimination by the immune system. The parasite remains in undetectable level in the blood, and can anytime start multiplication and can cause malaria symptoms. This is more common with P. falciparum, but this can happen with all forms of malaria parasites. And also, we have relapse. Okay, relapse is the renewed asexual parasitemia following a period in which the blood contains no detectable parasites. This occurs with P. vivax and P. ovale malaria. This is resulting from the reactivation of dormant hypnozoic forms of parasites in the liver cells. Okay, this next slide, it's a diagram. This diagram shows the different periods of malaria, from incubation period to parasitic relapse against the different levels of parasitemia as well as the presence of symptoms. The horizontal broken line down below represents the lowest possible level of parasitemia, which means radical or spontaneous cure, while the horizontal whole line right there around the middle, it serves as the microscopic threshold. So this threshold separates the subpatent parasitemia and the patent parasitemia. When a patient already has patent parasitemia, this is the time that symptoms are expected to occur, especially when the level of parasitemia increases. The diagonal broken line symbolizes the clinical or pyrogenic threshold. This one rises with increased immunity as the illness transitions to its later periods. This means that the amount of parasites in the bloodstream that have caused symptoms earlier in the disease may not produce symptoms at the latter part of the disease, or may not produce symptoms that are not as severe. Also, you can observe that during clinical latency, there is still presence of sublatent parasitemia as opposed to the latent period, as well as parasitic latency that considered as radically or spontaneously cured. That is, of course, until a relapse happens. The pathological process in malaria is resulting primarily from the erythrocytic cycle. As an example, P. falciparum merozoites invade the erythrocytes, which reduces the RBCs or red blood cells deformability. The degree is directly proportional to the parasite maturity. The reduction in the deformability is due to changes in the red blood cell cytoskeleton and increase in membrane stiffness and cytoplasmic viscosity. So right now we're moving on at the invasion of the disease. The merozoites invade the red blood cells with the following mechanisms. First, we have the electron-dense submembranous structure that appear and enlarge. Okay, they are also called nubs. They are important in cytoadhesion, and they contain several proteins. We have rositins, rifins, histidine-rich proteins or HRP, and Plasmodium falciparum erythrocyte membrane protein 1. This is the most adhesive protein among the nubs. The last one, the Plasmodium falciparum erythrocyte membrane protein 1. And third, the PFEMP1, okay, it is encoded by BAR. It is a multi-gene family and clonally variant, enabling it to evade specific immune responses by the human body. Rositins and PFEMP1, they have ligands for rosette formation. It lets merozoites adhere to parasitized and non-parasitized cells and blood platelets. And fourth, we have the febrile temperatures that induce the cytoadherence of the ring stage P. falciparum erythrocytes. The PFEMP1 is responsible for heat-induced cytoadherence, and the HRP enables localization to the cytoadherence ligands, making the adhesion more effective. So the infected erythrocytes undergo altered membrane transport mechanisms. The hemoglobin is digested, which releases hematin, and variant strain specific neoantigens are expressed. The soluble antigens of P. falciparum induce pro-inflammatory cytokines from monocytes and macrophages. GPI or glycosyl phosphatidylinositol moieties that are covalently linked to the surface of antigens of these protozoans act like the endotoxin of gram-negative bacteria, lipopolysaccharides. Um, the GPI stimulate the monocytes to release tumor necrosis factor or cachexin. This part of the process is implicated as the cause of malarial fever. The symptoms of acute malarial attack includes fever, febrile paroxysms, headache, various aches and pains, and frustration. They are a result of release of cytokines at the time of quiescent rupture. The combination of altered red cell surface membranes and the host's immunological response to the antigens bring about the following pathologic changes. Number one, there is an alteration in blood flow in the vascular endothelium. Second, there is altered biochemistry. Third, there is anemia. Fourth, there is tissue and organ hypoxia. And five, there are other destructive tissue processes such as increased capillary permeability, which allows fluid to leak into surrounding tissues, and congestion in blood vessels, resulting in tissue infarction and necrosis. So obviously, all these five changes are brought upon by the altered red blood cell surfaces. And moving on to the pathogenesis, there is impairment of consciousness and other signs of cerebral dysfunction, like delirium or generalized convulsion. They are observed in severe forms of malaria, secondary to altered blood flow, and tissue hypoxia. Um, there is also severe hemolytic anemia. Hematocrit is less than 20%, and hemoglobin is less than 7 grams per dl due to the decreased deformability of red blood cells. There is also hyperbilirubinemia, which is greater than 50 ml due to increased destruction of RBCs. Cerebral malaria can be observed with the following symptoms. There's hyperpyrexia, retinal hemorrhage, bruxism, mild neck stiffness, pouting or pout reflex. This may occur or may be elicited by stroking the sides of the mouth. If left untreated, symptoms can progress to paralysis, persistent coma, and death. The neurological symptoms are reversible if treatment are promptly or adequately given. The brain would appear congested upon visualization. Other diseases that can arise from malaria are altered pulmonary function. This includes airflow obstruction, impaired ventilation and gas transfer, and increased pulmonary phagocytic activity. There's also pulmonary edema. There is a high mortality rate when pulmonary edema develops in patients with severe malaria. And there's also acute renal failure. Complications can also occur in patients that are pregnant with malaria. There is increased risk of maternal death, maternal anemia, intrauterine growth retardation, spontaneous abortion, stillbirth, and low birth weight associated with risk for neonatal death. Non-immune pregnant women are susceptible to all complications associated with severe malaria, such as cerebral malaria, hypoglycemia, and pulmonary edema. While for partially immune pregnant women, especially preemies or premigravida, or a woman who is pregnant for the first time, severe anemia may develop, but other complications of severe malaria are unlikely to occur. Okay, so falciparum malaria in a young child is a medical emergency, for it can be rapidly fatal. The initial symptoms may be atypical and difficult to recognize, but within hours, life-threatening complications may start to occur. Okay, children with severe malaria most commonly present with seizures. These convulsions are common before or after the onset of coma, and are significantly associated with neurologic symptoms, like opisthotness, a type of abnormal posture where the back becomes extremely arched due to muscle spasms. The most common complication of severe malaria in children are cerebral malaria, severe anemia, respiratory distress, and hypoglycemia. Okay, and on this next slide, the table shows the signs and symptoms of severe malaria compared between adults and children. As seen from the table, if you're going to look at it, the children have shorter duration of illness and quicker resolution of coma. However, in contrast to adults, they have much more severe symptoms or complications, like they have a higher chance of neurological complications than adults, as well as hypoglycemia, pulmonary edema, and respiratory distress. Now we're gonna be moving on to the life cycle. Okay, so natural history of malaria involves cyclical infections of humans and the female Anopheles mosquitoes. So in humans, the parasites grow and first multiply in the liver and then in the red blood cells. And then when in the blood, successive broods of parasites grow inside the red cells and destroy them, thus releasing daughter parasites or merozoites. The merozoites continue the cycle by invading other red blood cells. And what happens in the liver after the sporozoites, the plasmodium form coming from the mosquito, when they infect the liver, they mature into schizons. These schizons rapture and release merozoites. Again, this is just happening within the liver, and this whole process from the sporozoites into mature schizons, releasing the merozoites. This is a process called exoerythrocytic schizogony. This is the initial replication in the liver. This can be understood with the name itself, coming from the word exo, which means outside, and erythrocytes for RBCs. So again, if it's replication on the liver, that's exoerythrocytic schizogony. Okay, and next, as mentioned earlier, in P. vivax and P. ovale, a dormant stage called hypnozoites can persist in the liver if untreated. This can cause relapses by invading the bloodstream weeks or even years later. So they can stay at the liver or liver cells for a very long time. Okay, and again, looking closer in the blood, after the exoerythrocytic schizogony in the liver, the parasites undergo a sexual multiplication in the red blood cells. And now this phase is called the erythrocytic schizogony. Okay, and merozoites infect red blood cells. The ring stage trophozoites mature into schizons, which again ruptures, releasing the merozoites. And these newly released merozoites will again reinfect or infect new red blood cells. Some parasites differentiate into sexual erythrocytic stages or gametocytes. Okay, so the blood stage parasites are those that cause the symptoms of the malaria. These certain blood stage parasites occur in both in female form. The gametocytes are ingested during blood feeding by a female Anopheles mosquito. If it's a male gametocytes, it's called a microgametocytes. When it's a female, it's a macrogametocytes. Okay, so in the female Anopheles mosquito, this is how it goes as for the cycle. Okay, the parasite's multiplication in the mosquito, it is called as sporogenic cycle. They mate in the gut. That's the micro and macro gametocytes, the male and female. They mate in the gut of the mosquito and begin a cycle of growth and multiplication. The microgametes penetrate the macrogametes, generating zygotes. The zygotes in turn become motile and elongated, which is then called ookinids. And they invade the midgut wall of the mosquito, where they develop into oocysts. The oocysts grow, rupture, and release sporozoites, which make their way to the mosquito's salivary glands. And then when the Anopheles mosquito take a blood meal on another human, the anticoagulant saliva is injected together with these sporozoites, which then migrate again to the liver of the human, and thereby beginning a new cycle in another human. This diagram below, okay, this next slide is taken from the CDC website. You can go visit their website to review the image. But basically, this shows the things we just discussed. The entire cycle from the mosquito bite, where the sporozoite came from and injected into the human body, and the events that take place up to the sexual differentiation of the immature trophozoite to male and female gametocytes, which is then again ingested by a mosquito during a blood meal, allowing the gametocytes to mate in its gut to produce new parasites. This next diagram in this next slide is just it just shows the same cycle. However, this one has a distinction of the presence of the hypnozoite form, which is labeled as 1A in this diagram. Again, this is only present in P. vivax and P. ovale and are responsible for relapses. Um, Next slide, this third diagram, it shows the different stages of maturation of the trophozoite form, from the immature ring stage up to a fully mature schizont. And the last picture showing the merozoites after the mature schizont ruptured, ready to infect other red blood cells. Length of the developmental cycle in the mosquito depends not only on the species of Plasmodium, but on the particular mosquito host and ambient temperature. It may range from as little as 8 days, like in P. vivax, to as long as 35 days, like in P. malariae. Later development of P. falciparum and P. malariae differs from that of P. vivax and P. ovale. In all four species, a sexual multiplication takes place within the liver cells, but with P. vivax and P. ovale, a varying proportion of the infecting sporozoites enter a resting stage. Again, this is what we call the hypnozoites, before undergoing a sexual multiplication, while others undergo this multiplication without delay. The resting stage of the parasite, again, is known as the hypnozoite. After a period of weeks or months, reactivation of the hypnozoite initiates a sexual division. While hypnozoites have not been observed in human infections, their presence in P. vivax and P. ovale is inferred from experimental observations. Now let's move on to the morphology. Okay, first we have the ring forms, or the early trophozoites. This is the one most commonly seen. Ring-like appearance following invasion into a previously healthy RBC. So from the merozoites that are released from the liver cells into the bloodstream, when they invade the red blood cells, the first stage is the ring form, or the early trophozoites. Excuse. When stained with gemcistain, you will see a blue cytoplasmic circle connected with, or to, depending on the species, a red chromatin dot. This can also be referred to in some texts as a nucleus. The space inside the ring is known as a vacuole. More often, two or more ring forms are found in a single RBC. Next, we have the developing trophozoites. There is a large chromatin mass and a prominent amoeboid cytoplasm, which is spread through the erythrocyte. It is a small, delicate, and measures 1.25 to 1.5 micrometers. However, remnants of the cytoplasmic circle and chromatin dot, which are in some cases both still intact until late in development. They are present in developing trophozoite form. Pigment, primarily brown in color, is often visible. In general, because the parasite is actively growing during this stage, the amount of red blood cell space invaded is significantly more than that of the ring form. The next stage of development is the immature schizonts. The parasite develops into schizonts when the chromatin has divided into two or more masses of chromatin with small amounts of cytoplasm. 4.5 to 5 micrometer in diameter and occupy about 2/3 of the infected RBC. Although still unorganized, evidence of active chromatin replication is seen in the typical immature schizont. Visible cytoplasmic material surrounds the growing chromatin. Pigment granules, often brown in color, are commonly seen. As the parasite continues to multiply, it expands and occupies more space within the red blood cell. As you can see in this picture, the schizont is getting larger and larger within the red blood cell. However, the appearance of the developing trophozoite varies among the Plasmodium species. There are numerous growing stages in this category for each organism. Next stage is the mature schizons. Mature schizons are characterized by the emergence of the fully developed stage of the asexual sporozoa trapezoid known as merozoites. 10 to 36 merozoites arranged in a grape-like cluster. They measure 5 to 10 micrometers in length, and clumps of pigment accumulate in the middle of a mature schizon. With the exception of Plasmodium vivax, cytoplastic material is not visible and is presumed to be absent. Schizons are very rarely seen in the peripheral blood smear, and there are presence of schizons in the presence of schizons in peripheral blood suggests severe infections. Again, the most common form that you will find is the ring form. The number and arrangement of these merozoites vary and are described in detail under the discussion of each malarial species later in this report. Okay, so we're going to be moving on to the microgametocytes. This is the male gametocytes. With the exception of P. falciparum, which is crescent shaped, the typical microgametocyte is roundish in shape. This morphologic form consists of a large diffuse chromatin mass that stains pink to purple and is surrounded by a colorless to pale halo. The cytoplasm is colored lighter blue, and pigment is usually visible. Its distribution and color vary by species. And we also have the macrogametocytes. So this is the female gametocyte. Macrogametocytes range in shape from round to oval, with the exception of P. falciparum, again, which is crescent shape. The compact chromatin mass is partially to complete surrounded by cytoplasmic material. As contrast to microgametocytes, its cytoplasm has a darker blue color. Pigment is also present, and its color and distribution in this morphologic form may vary from individual Plasmodium species. Okay, so that is it for my part of the report, and here's the next one. Thank you.
We will be discussing malaria parasite development in the mosquito host. Okay, so let us remember that there are actually two phases of the cycle of the malaria parasite. We have your asexual phase and your sexual phase. Okay, the asexual phase actually occurs in humans, while the sexual phase occurs in the mosquitoes. Okay, so let us look at the diagram. So as we see here, this shows us the different stages of the malarial parasite in the mosquito host. Okay? Okay, so this cycle starts when the mosquito takes a blood meal. Okay, tatandaan natin po na dapat si mosquito nag-blood meal kanino? In an infected individual. Okay? So, from the infected individual, they will have your gametocytes, and when the mosquito takes in the blood, what happens is the gametocytes are transferred into the mosquito. Now, what happens in the mosquito is that the gametocytes fuse, okay? So, the gametocytes or the gametes, they fuse together, they form what we call as the zygote, okay? Now, this is actually the sexual phase ng ating pong life cycle ng ating malaria. Tatandaan natin na the actual fusion of the gametes occurs in the mosquito. That is why mosquitoes are actually the definitive host of your malarial parasites. Okay? They are the definitive host of your malarial parasites because it is where the sexual phase occurs. Okay? Now, eventually, the zygotes develop to become your ookinids. Ookinids are actually motile forms of the parasite, and what happens is that they invade the midgut epithelium. Okay? They invade the midgut epithelium, and eventually they encyst there to become your oocyst. Okay? So, review, sang pasadahan. Gametes galing sa infected individual. Once inside the mosquito, what happens is that the gametes fuse to become the zygote. The zygote further develops to become ookinete, and the ookinete will become motile and will what? Will invade the midgut epithelium. Now, from there, the ookinete will develop into an oocyst. Okay, what happens next? Yung atin pong oocyst natin will mature and it will contain what we call as your sporozoites. The sporozoites later on will what? They will migrate to the salivary glands of the mosquito. Now, in this phase, when the sporozoites have already migrated into the salivary glands of the mosquitoes now are infective. Okay? Let us remember that the sporozoites are the what? They are the infective stage 2 humans. Okay? Sporozoites are the infective stage 2 humans. Okay? So, yung sexual cycle natin, it starts with the gametes, ends up with the sporozoite. Okay po? Okay po. So, next slide tayo. Yan. So, we have here ookinete and the oocyst. So, once again, following an infectious blood meal, take note the term infectious. So the mosquito must take a blood meal from an infected individual. So, Plasmodium gametocytes are activated, resulting in the emergence of male and female gametocytes. After fertilization and the formation of a zygote, parasites undergo meiosis and transform into a motile ookinete. While the precise timing of the ookinete invasion varies depending on the Plasmodium species, ookinites must penetrate the peritrophic matrix surrounding the blood meal and invade the midgut epithelium. So after successful transversal, ookinites differentiate into sessile oocysts on the basal surface of the midgut epithelium. So as we have discussed it already kanina, isang pasadahan, gametes magfuse, magiging zygote, zygote magiging ookinete, ookinete i-invade yung midgut epithelium, mag-encyst, magiging oocyst, oocysts will develop sporozoites. Sporozoites will be released. They migrate into the salivary glands. Now what happens is that the mosquito is now infective. Okay? Okay, so this is what the figure tells us here. And it mentions some of the proteins. Proteins associated with salivary gland invasion are your PRS1, Saglin, and SRPN6. Proteins associated with midgut invasion are your TEP1, APL1, Caspar, and Cactus. Okay? Okay, so those are the necessary proteins needed for the invasion. Ano mga in-invade? In-invade yung midgut. Pangalawa, in-invade yung salivary glands. Okay? Okay. So let's go to the comparison of morphological features of malarial parasites. Okay? Comparison of morphological features of malarial parasites. This is significant especially in the differentiation or differentiation natin of the species of malaria. Okay? Kasi po, magkakaiba sila ng presentation. Although, yes, they are all malaria, but they have different severity and they affect red cells differently. Okay? So, there are different parameters wherein we can differentiate the Plasmodium species. The most common species that we differentiate are Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. Although we already have the Plasmodium knowlesi, however, knowlesi is quite rare when compared to the following Plasmodium. Okay? So the first parameter that we use for differentiation is the morphology of the infected red blood cells. Okay? So for your Plasmodium falciparum, also known as your malignant tertian malaria, RBCs appear normal with multiple infection of RBC natin. Okay? So, it is very common for Plasmodium falciparum to invade red cells and have multiple parasites in a single cell. Okay? Kaya usually for differentiation natin, isa sa mga tinitignan. We call it the super infection. Okay? Super infection wherein for a single RBC, we have multiple parasites in it. Okay? This is very common in Plasmodium falciparum. Although we can also see it in other species of the Plasmodium such as in Vivax and in Ovale. Okay? One thing to note is that for the differentiation of the species, Plasmodium vivax will appear. Plasmodium vivax will make red cells appear larger than normal. Okay, the red cells infected by Plasmodium vivax, they appear larger than normal. They have pale, often bizarre, and of course they have what we call as your Schaffner's dots. Okay, Schaffner's dots are often present, and multiple infection of RBC is not uncommon. So not uncommon, yeah, we may see them. However, not as common as what we see in Plasmodium falciparum. Okay? Okay, so mga things to take note for Vivax, size of RBC is enlarged and it contains Schaffner's dots. And often, meron tayong pinapares sa kanya na halos kapareho niya yung atin pong Plasmodium ovale. Okay? Plasmodium ovale, red cells appear somewhat larger than normal, often with fringed or irregular edge. Okay? And oval in shape. Of course, we also see Schaffner's dots. So when we hear Schaffner's dots, we think of two parasites. We have the Plasmodium vivax and Plasmodium ovale. Okay? Plasmodium vivax and Plasmodium ovale. So, stains readily and deeply done in Plasmodium vivax. Next thing is your Plasmodium malariae. Plasmodium malariae is RBCs appear normal or sometimes smaller. Okay, so in some books they may say they may be 0.75 times or 3/4 the normal size of RBCs, or they may be normal. Okay, so most of the parasites seen on thin smears, most of the parasites will invade cells that are slightly smaller or normal in size compared to uninfected RBCs. So we have mentioned here Schaffner's dots for Vivax and Ovale. Actually, we also see other dots for other parasites. For example, for Plasmodium falciparum, we may see what we call as your Morer's dots. For Vivax, we also see Schaffner's dots. We have already mentioned it. For Ovale, we also see James dots. Aside from the Schaffner's dots, sometimes we also see what we call as your James dots. And while for your Plasmodium malariae, we see Zeeman's dots. Okay, Zeeman's dots. And usually sa review, ginagamitan to ng mga mnemonics natin. For Plasmodium falciparum, sabi nila daw, FM, siyempre Ferdinand Marcos, sabi nila, Plasmodium falciparum. For your Morer's dots. For Vivax natin is Vilma Santos, sabi nila, Vilma Santos. Vivax for Schaffner's dots. For Plasmodium ovale, O.J. Simpson. Plasmodium ovale, O.J. Simpson stands for James and yung Schaffner's dots natin. For Malariae, Manila Zoo, sabi nila, Manila Zoo. Okay? So, for Plasmodium malariae, we have Zeeman's dots. Okay? For the next parameter, for the next stage, which is the small trophozoites, for falciparum, they have the same morphology as P. vivax, but with small thread-like blue cytoplasmic circle with one or two small red chromatin dots. So, one thing to differentiate Plasmodium falciparum from Plasmodium vivax is that for P. falciparum, we often see what we call as double dots. Okay, double dots or double chromatin natin. Okay, so we also see marginal forms. For Plasmodium vivax, we have the signet ring form with heavy red dot and blue cytoplasmic ring. Okay, signet ring form with heavy red dot and blue cytoplasmic ring. For Plasmodium ovale, small, darker in color, and generally more solid than those of P. falciparum. Schaffner's dots regularly present in almost 100% of infected cells. And for Plasmodium malariae, we have They are similar or same with Plasmodium vivax but with blue cytoplasmic circle, smaller, thicker, and heavier. Okay? Next. Ayan. So this is the appearance natin. So as we can see here, we observe that for the Plasmodium falciparum, we observe double dots natin. And nabanggit natin kanina that we also see superinfection wherein we see multiple parasites in a single red cell. So we can see here in P. falciparum. For P. vivax, we have here the signet ring formation. For P. ovale, we have here common natin ng mga Schaffner's dots natin. For P. malariae, we have a thicker. As we see here, we have a thicker cytoplasmic ring compared to the others. Kasi yung iba maninipis lang. For P. malariae, oftentimes we see a thicker ring. Okay? Next. For the growing trophozoite, for P. falciparum, it remains in ring form but grows resembling a small trophozoite of P. vivax in size and usually the oldest asexual stage seen in peripheral blood. It must be taken to note that in P. falciparum, not all the stages of the parasite can be seen in the peripheral blood. Okay? Usually, we only see the ring forms and the gametocytes. Other stages natin, we usually don't see them. Okay? But for other parasites, P. vivax, P. ovale, P. malariae, oftentimes we see most of the stages can be seen in peripheral blood. Okay? For P. vivax, the growing trophozoite appears like small trophozoite and as previously stated, with increased cytoplasm and amoeboid activity. Small yellowish brown pigment granules in the cytoplasm which increases with age of the parasite. For P. ovale, it resembles closely as your P. malariae but is considerably larger. Pigment is lighter and less conspicuous. For P. malariae, chromatin is surrounded or elongated cytoplasm, compact or in narrow band across cell. So, dark brown granules may have peripheral arrangement. Okay? So, one of the common recalls that we hear before is for P. malariae, we often hear what we call as band forms. Okay? So, kung may narinig kang band, yan, si P. malariae usually. Makikita natin dyan. Okay? Here's an example of the images that we see. For P. falciparum, the glowing trophozoites, as we have described here, when we try to see the red cells that it infects, ano meron dyan? Halos magkasing laki lang sila. The infected RBC has almost the same size as the uninfected RBCs. For P. vivax and P. ovale, what we see here is that we compare the size of the infected red cell compared to the neighboring red cells. Mas malaki sila. Mas malalaki yung infected natin na cells compared to the normal or uninfected cells. And for P. malariae, we see here a band. Okay? Yan nakikita natin dyan is that is, yan yung tinatawag nating band. Okay? Okay, for the large trophozoites. For P. falciparum, as I have mentioned a while ago, ang atin pong mga stages niya, usually not all stages are seen in the peripheral blood. That is why we rarely see them. Okay? They are seldom present. For P. vivax, large mass of chromatin, loose, irregular, or close compact cytoplasm with increasing amount of brown pigment. Okay? Parasite fills cells in 30 to 40 hours natin. Okay? For P. ovale, it is also usually seldom present. For P. malariae, chromatin often elongate, indefinite in outline, cytoplasm dense, compact, in rounded, oblong, or band forms. Pigment granules are larger, darker than P. vivax parasite, fills cells frequently. So, nabanggit natin kanina na ang atin pong P. malariae, usually nandyan, basta narinig natin yung band. Parang, yan, mga parang recall question, mga yan. Okay? Next po. For the schizoid, ito po. Banggit natin, naman kanina, not all stages of the development of the parasite of the Plasmodium natin. For Plasmodium falciparum, not all the stages are seen. Okay, tatandaan. For example, the schizoid is not present in the peripheral blood of patients infected with P. falciparum. For P. vivax, the schizoids appear with divided chromatin. Okay. Cytoplasm shows varying degrees of separation into strands and particles. Pigment collects in parts of the parasite. For Plasmodium ovale, about 25% of infected cells are definitely oval shaped. Usual picture of that of a round parasite in the center of an oval cell and many cells with a definite fringe outline. Pigment lighter and less coarse than P. malariae. Another thing that we can associate with P. ovale, pag narinig natin yung word na fringe, okay? We have here fringed outline natin ng atin pong red cell that it is that it has infected. Oftentimes yan, mga tinitignan natin na signs kung P. ovale siya. Okay? For P. malariae, it is same as P. vivax except parasite is smaller and shows less chromatin division and more delayed clumping of pigment. So, ayan. Makikita natin, dyan sa pictures natin, makikita natin yung description natin. For P. malariae, less chromatin division. For P. ovale, we have a fringed outline and oval cell. And for P. vivax, we have divided chromatin. And of course, for P. falciparum, we don't see that in the peripheral blood. Okay. However, there were some cases wherein the skyzont was actually seen in the peripheral blood. And when does this happen? Usually, this happens in cases of patients with cerebral malaria. Okay. That is the reason kung bakit ang atin pong P. falciparum is one of the most pathogenic and most virulent natin is that it causes cerebral malaria. Now, the only time we see skyzones sometimes na makikita daw is when in the case of cerebral malaria. So, yun. Next po. Yan. For P. falciparum, yan. We have mentioned, although they are seldom seen natin in the peripheral blood, if seen, usually it is associated with cerebral malaria. Kaya nabanggit dito, mature skyzones are rarely present and they will contain 8 to 24 merozoites. Okay, 8 to 24 merozoites and smaller than other species natin. For P. vivax, the skyzone contains around 12 to 24 merozoites and pigments in 1 to 2 clumps, and parasites almost fills enlarged cells. Okay, fills the enlarged cells. For P. ovale, usually 8 merozoites arranged around a central black pigment. So, another recall here for P. ovale is that we may see rosette RBC that has jagged edges. Jagged yung nasabi natin kanina, parang fringe or jagged edges, and irregular merozoite arrangement. For P. malariae, we have 6 to 12 or average of 8 to 10 merozoites in rosette form, and parasite almost fills the cell. So, ito po yung appearance niya sa image natin. As we can see the outline ng ating pong P. ovale, makikita natin na meron tayong mga jagged na borders natin. Okay? For P. vivax and P. ovale, we observe or we try to compare the cells surrounding it. Usually, mas malaki yung cell natin, mas malaki yung ating infected cell compared to the surrounding or neighboring cells natin. Okay? For P. malariae, we often see rosette formations. Okay? Yan. Next po. For the gametocytes natin, the morphology of the gametocytes, for P. falciparum, usually, nasabi ko kanina, the most common stages that we see for P. falciparum on the peripheral blood will be the gametocyte and yung atin pong ring forms natin. Okay? For the gametocyte of P. falciparum, it is present in peripheral bloodstream and similar to P. vivax, it will have the crescent or sausage shape. Actually, another description that we can use is banana shape. Banana shape gametocyte, crescent shape gametocyte, sausage shape gametocyte. Okay? For P. vivax, the microgametocyte is light red to pink chromatin with diffuse or central na distribution. It gives tint to light blue cytoplasm and yellowish brown pigment throughout the cytoplasm, and usually round and about the size of normal RBC for the microgametocyte. For the macrogametocyte, it is a small, compact, dark red eccentric chromatin, and the cytoplasm is dark blue and no vacuoles, and abundant dark brown pigment scattered throughout the cytoplasm. For P. ovale, It is distinguished from P. malariae by the size of infected cells and by Schaffner's dots, and less easy to differentiate with P. vivax. As I've mentioned, P. vivax and P. ovale have very similar na morphology natin. Now, for P. ovale compared to P. malariae, nasabi naman natin kanina, that one way to differentiate them is to look at the size of the red cells they have infected. For P. ovale, usually the red cells are enlarged. For P. malariae, usually the red cells are normal or sometimes smaller than the neighboring normal cells. Okay? For P. malariae, nasabi natin kanina, same as P. vivax, however, except it is smaller and fills or almost fills the cells. For P. knowlesi, let us take note that your Plasmodium knowlesi is microscopically indistinguishable from P. malariae. Okay? Sunod po. Here, ito na yung mga parang things to remember natin para sa specific natin ng mga parasites natin. So, for Plasmodium falciparum, infected erythrocytes, usually ang size nila normal size. Okay? Rings natin are double chromatin dots or Acol forms. Multiple infections in same red cell. Sabi natin kanina, superinfection. When we see the red cell with multiple parasites in it, yan, that is usually associated with Plasmodium falciparum. Also, when we see double chromatin dots, Plasmodium falciparum. Next is the gametocytes natin. The gametocytes can be your mature or the immature forms. For the gametocytes, one way to describe is it can be in sausage shape, it can be crescent shape, it can usually be banana shape. Okay? Yun yung mga ginagamit na terms to describe yung atin pong gametocytes. Okay? Gametocytes. For trophozoites natin, it is compact and rarely seen in the peripheral blood. Bakit po? Nasabi ko kanina, ang usual na nakikita in the peripheral blood will be rings and the gametocyte stages natin. Para kanino? Kay Plasmodium falciparum. When seen, ito po yung itsura niya. It has a compact appearance. For schizons, ganun din. Schizons are rarely seen in the peripheral blood. Sabi ko kanina, when we see schizons in the peripheral blood in cases of falciparum, malaria, ano po meron dito? It is usually associated with cerebral malaria. Okay? Yan. So the schizons appear to have 8 to 24 merozoites and nasabi kanina, it is rarely seen in the peripheral blood. Okay po? Next po. Yan. For Plasmodium vivax, infected RBCs are enlarged up to 2 times. Okay? They are enlarged up to 2 times and often deformed and they contain the Schaffner's dots. Okay? They contain Schaffner's dots. So here's the appearance of rings for your Plasmodium vivax. We have mentioned a while back that how do we describe it? They have signet ring appearance. Okay? For the trophozoite, they are amoeboid and they deform the RBCs natin. So let us take note, ulitin natin, look at the image hanggang masanay. The parasite, when it infects a red cell, it enlarges the red cell. So how do we note that? We just look at the neighboring cells that are uninfected. So as we see in these pictures or these examples, the red cells that are infected are larger compared to the surrounding uninfected red blood cells. Okay? For schizons of the Plasmodium vivax, we usually see this compared to falciparum naman natin na bihira ang schizons. Schizons of P. vivax will contain around 12 to 24 merozoites. And for the gametocytes, they have round to oval shape na gametocytes natin. For the macrogametocytes natin. Okay? Okay. So, ayan. So, kung kanina, si Plasmodium falciparum is banana shape or elongated, yung atin pong crescent or sausage. For the P. vivax, it is round to oval. Okay? For Plasmodium ovale, ayan, infected erythrocytes are moderately enlarged. Okay? They are moderately enlarged with fimbriated na borders natin. Fimbriated borders. Yung mga nabanggit na term natin kanina, ano yung mga yun? Jagged, fimbriated, fringed. Yan. Yung mga terms natin na yan associated with Plasmodium ovale. Yung borders of the infected cell will have jagged, fimbriated, or fringed borders natin. Okay? Siyempre, kaya siya tinawag na ovale because Yan. Cells consistently appear as oval cells natin. Also, it contains Schaffner's dots. Okay? It is a malaria-like parasite in vivax-like erythrocyte. Yun yung common na description. Malaria-like parasite in vivax-like erythrocyte. Paano sasabihin dito? Kasi sa malaria, usually ang appearance ng atin po, halimbawa, cytoplasmic rings natin, they appear thicker. Pero yung cell is enlarged. Ano meaning nun? Ibig sabihin, hindi siya malaria, di ba? Tatandaan na ang atin pong size of the erythrocyte is usually associated kung anong species yung naka-infect sa kanya. And enlarged RBCs natin are usually associated with dalawa lang, ovale and vivax. Okay? Ovale and vivax. Okay po? Yan. So rings, we see here, the thicker rings compared to Plasmodium falciparum. Trophozoites natin are compact. Schizons contain around 6 to 14 merozoites and associated with rosettes, dark pigment rosettes. For gametocytes, they are also round to oval. Okay, round to oval na gametocytes. And for Plasmodium malariae, infected erythrocytes is the size is normal to decrease around 3/4 of the original size. So when we see a cell that has a parasite that is normal or sometimes smaller, that does not look like Plasmodium falciparum, na ganito yung itsura niya. We have thicker, ano ba mga nabanggit natin kaninang mga associated sa kanya? For trophozoites, they appear to be compact with thick cytoplasmic rings. For the another form of the trophozoite natin that is more typical, yung binanggit kong term kanina, band. Okay? When we see band forms for the parasite, usually that is Plasmodium malariae. Okay? For the schizont, it will contain 6 to 12 merozoites and coarse and darkly pigmented. And gametocytes appear round and coarse with dark pigment. Okay? So as we hear sa gametocytes natin, this is one way to differentiate it from other parasites. Kasi sino na lang yung may banana shape? Si Plasmodium falciparum. The rest are round to oval na gametocytes natin. Okay? Okay po. Here, so this slide summarizes the species differentiation on thin films. Okay, on thin films. So we have here the different features, ulitin, enlarged infected RBC, infected RBC shape, stippling infected RBC, trophozoite shape, chromatin dot, mature schizon, and gametocytes. These are the different parameters of differentiation. For enlarged RBCs natin, we see here that only P. vivax and P. ovale will have enlarged RBC. Okay? For infected RBC shape, for P. falciparum and P. malariae, they are usually round. Okay? Round. Kasi hindi naman nila na-affect yung laki ng cell natin. For P. vivax and P. ovale, we see here, for P. vivax, it is round and distorted. And for P. ovale, we have here the characteristic oval and fimbriated. Okay? For P. vivax, ulitin, it is round and distorted. But for P. ovale, it is oval, consistently oval, and fimbriated. Mga other terms na pwedeng gamitin, nasabi natin kanina, fimbriated, jagged, ano pa ba? Fringe, mga ganun na appearance natin. Stippling of infected RBCs, okay? Although what's only placed here is the Morers clefts or the Morers dots. Morers is associated with falciparum. Ano yung mnemonics natin kanina? Ferdinand Marcos. For P. vivax, we have your Vilma Santos, kaya Schaffner's dots. For P. ovale, ano nung mnemonics natin kanina? O.J. Simpson. Okay, O.J. Simpson. Bali ovale will contain James dots and Schaffner's dots. Okay? For P. malariae, although it says here none, there are sources that say that we have Z-Mans dots naman. Z-Mans, okay? Z-Mans dots. Kaya Manila Zoo ang atin pong mnemonic sa kanya. For the trophozoite shape, for P. falciparum, we have small ring or applique forms. For the P. vivax, large ring and amoeboid. For P. ovale, large ring and compact. And for P. malariae, small ring and compact. Okay? Kaya nabanggit nga kanina, di ba, meron tayong, anong sabi natin sa description sa ovale? Malaria cells in vivax erythrocytes, sabi nila, di ba? Kaya they appear to be compact din. Okay? For the chromatin dots, we have mentioned, isa lang naman yung atin pong keyword na nabanggit kanina. Double dots or double chromatin dots natin, saan natin narinig kanina yan? Kay P. falciparum. Okay? tandaan, often double, P. falciparum, natira usually single, okay? For P. vivax, single, for P. ovale, large, and for P. malariae, single. For mature schizons, ulitin na naman natin, ulitin ang kumatandaan, P. falciparum will usually not have schizons sa peripheral blood. However, when seen, they will contain usually 12 to 30 merozoites. Okay? For P. vivax, 12 to 24 merozoites. For P. ovale, 4 to 12 merozoites. And for P. malariae, 6 to 12 merozoites. Okay? And the gametocytes natin, isa lang nabanggit natin kanina na naiiba. Okay? For P. falciparum, it will contain banana shape, crescent shape, or sausage shape na gametocyte. For P. vivax, it will have a large and round gametocyte. For P. ovale, a large and round gametocyte. And for P. malariae, compact and round gametocyte. Okay? Yan. So, this is the summary ng pictures naman natin nung how do we differentiate yung atin pong mga parasites natin. For the rings, nasabi natin kanina, for P. falciparum, we see here a normal size RBC with double dot of chromatin. For P. vivax, signet ring appearance. For P. ovale, this is kind of difficult kasi yung rings niya will be similar with other parasites, but we just look at the RBC. Okay? Tignan natin yung RBC natin. The borders of the RBC are actually fimbriated. Okay? Fimbriated, or makikita natin na irregular yung border niya. For P. malariae, we have here a normally sized RBC with a very thick na cytoplasmic ring. Okay? Okay. So, ganun din. For the trophozoites natin, we see here sa P. falciparum, this is quite rare, but we see here a compact na trophozoite. For P. vivax, we observe a very distorted na RBC, enlarged and distorted RBC. For P. ovale, an enlarged and oval shaped RBC. And for P. malariae, we see here a band form. Ito yung band na sinasabi natin, which is common. For the schizons, we just count here the number of the merozoites and the size of the RBC infected. For the gametocytes, isa lang po yung ating nakikita natin na naiiba, which is your P. falciparum. Okay? Actually, when we look closely into the picture of P. falciparum here, we observe that the red cell here, meron tayong nakikitang thin rim dyan, di ba? May thin rim of hemoglobin pa tayong nakikita dyan compared to the other sides. Di ba makikita natin dyan, parang may thin rim pa yan. This is what we call actually as a ghost cell, ghost RBC. Okay? Ghost RBC natin po is technically a cell that is almost dehemoglobinized na. Wala na siyang RBC, wala na siyang hemoglobin. Other term is annulocyte or ghost cell natin, wherein almost all the hemoglobin are already depleted. It was consumed by the parasite. Okay? Yan. Next po. Species differentiation on thick films naman tayo. Ayan. So, for features natin, we have here uniform trophozoites, fragmented trophozoites, compact trophozoites, pigmented trophozoites, and irregular cytoplasm, stipplings, and schizons visible natin, and gametocytes visible. Okay? For uniform trophozoites natin, we usually see here in the falciparum. Okay? For fragmented trophozoites, P. vivax natin will have common na fragmented trophozoites and P. ovale. One reason kung bakit hindi nakikita tong mga to dito sa P. falciparum is that usually we don't see the trophozoites naman in the peripheral blood for P. falciparum. Compact trophozoites naman are usually seen in P. ovale and P. malariae. Pigmented trophozoites for P. malariae. Irregular cytoplasm in P. vivax and P. ovale. Stipplings natin can be seen in P. vivax and P. ovale. And schizons, sasabi natin kanina. For P. falciparum, schizons are rarely available or rarely seen saan po sa atin pong peripheral blood. For gametocytes natin, we occasionally see for P. falciparum, but they are distinctive in the morphology. Tandaan, siya lang naman kasi yung may banana shape na gametocyte. Banana shape, sausage shape, crescent shape. The rest are round oval. Okay? Next po. Yan. Punta tayo sa laboratory diagnosis of plasmodium or malarial infections natin. Okay? Ito po. So for the microscopic examination, we follow by the simple rule natin for malaria. Isa sa mga common na ginagamit nating motto for parasitology. Usually hindi katulad sa sa bakte. But for parasitology, usually isa sa common na motto natin is Jack Pati Jack Kita. Yan, di ba? To see is to believe. Kaya usually we do microscopic examination. Okay? Microscopic examination. Simple and gold standard test for diagnosis of malaria is usually microscopic examination. And until this very day, we still heavily rely on microscopic examination for diagnosis of malaria. Okay? So, things that we should see is that we specify morphological patterns. Kaya nga, nakita natin kanina, ini-study yung different stages, anong appearance nila, that is necessary for differentiation. Okay? 0.0001% parasitemia detection natin, even in just using 5 to 10 microliters natin ng blood sample natin. Okay? Thick and thin blood smears is stained with GEMSA or right stain, and syempre the specimen natin is blood. Usually, ginagamit natin na blood is peripheral blood, mga finger stick natin, mga yan. Yan yung ginagamit natin usually. And then we prepare two types of smears, the thin and the thick smear. Okay? And then let us take note na magkaiba po ng gamit si thin and thick smear natin. Okay? The thin smear is usually used for speciation or for identification of the parasite. Okay? Kasi in the thin smear, we can appreciate the morphology of the parasites. Okay? But for detection, but for quantitation of the parasitic load, usually we use the thick smear. Okay? We use the thick smear. Okay? Yeah, so blood specimens ideally are collected just before the next anticipated fever spike. Paano na-anticipate? How do we anticipate? Let us take note that for malaria, they exhibit what we call as paroxysm. Okay? They exhibit what we call as paroxysm. So we can determine when will be the next stage. It has been discussed earlier na meron tayong paroxysms ang atin pong malaria. There are different stages and we can predict kung kailan i-spike yung next na fever. Okay? So blood specimens ideally are collected just before the next anticipated fever spike. One of the reasons is that this is the time wherein we can see the parasites actually inside the RBCs. Okay? This is what we call the erythrocytic cycle, di ba? Wherein the red cells are infected by the parasites. Okay? Ayan. So specimens drawn several hours apart sometimes may be required to demonstrate infection or to diagnose the species because the number of and morphologic stages of parasites vary during the cycle. So careful examination of thick films should reveal the presence of the parasite in almost all patients with clinically apparent malaria. Okay? Ayan. So in falciparum malaria, only the ring forms may be found but 10 days after the symptoms begin, gametocytes may be found as well. So nasabi natin kanina, for falciparum malaria, usually we only see two stages, the gametocyte stage and the ring forms natin. Okay? This may have been continued until a diagnosis of malaria is made or until malaria can be confidently ruled out. Okay? So one thing na reason kung bakit tignan natin yung gametocytes din is that Plasmodium falciparum actually morphologically resembles another parasite which is your Babesia microti natin. They appear to have similar ring forms. However, for Babesia, they will never have the gametocyte stages. O yun naman, mga tinitingnan natin, this microscopic studies natin of the parasites, knowing what stages are seen is very significant in the diagnosis because it helps you differentiate the other causes of the infection. Okay? When malaria is a serious condition, this may require repeated testing for several days in order to demonstrate a positive result. Okay? Yan. So, Even after the diagnosis of malaria has been made, peripheral blood smears should still be obtained to monitor the response to treatment. So in individuals who are not seriously ill, monitoring once daily may be sufficient. So seriously ill patients should be monitored 2 or 3 times daily until significant improvement occurs. So by monitoring, we can see if the patient responds to the treatment. Okay, if the patient responds to the treatment. Monitoring should be continued until there is a clearance of the parasitemia. Okay. Here. So, how do we recognize the different stages? So, nabanggit dito, recognizing erythrocytic stages natin. Bakit po ba? Meron kasi another term, the exoerythrocytic stages naman natin, which will not be seen in the peripheral blood. However, the one we see in the peripheral blood is actually the erythrocytic stages. So, we have here ring forms, trophozoites, schizons, and the gametocyte. So, ayan yung mga simple natin na description natin. We have here a ring which contain a thin rim of blue cytoplasm. Trophozoites will have a larger shape with yan, yung atin pong with red chromatin. For schizons, it will have multiple red dots or multiple chromatin. And for the gametocyte, usually halos nilaki niya na yung buong cell, and it will contain pigments. Yan. So these are the different parts of the parasite that we can identify, that we can appreciate using the microscope. Okay? So of course, we see the chromatin dot or the red chromatin natin. Usually the vacuoles are clear, they will not be stained. For the cytoplasm, it is usually blue. Yan yung tinitignan natin kung sino yung mas makakapal. Diba? Sabi natin kanina, halimbawa, Malaria will have a thick cytoplasmic ring. For Falciparum will have not so thick, bali thin lang siya na cytoplasmic ring. And it will contain pigments. They may contain pigments such as pigmented trophozoites seen in Plasmodium malariae. And we also see stipplings. Okay, we may also see stipplings. And syempre, yan. So for the thin blood smear, one cell thick with cellular including the RBCs lying flat on the glass surface. Cellular elements are fixed and remain intact and recognizable. So we can use 0.005 microliters of blood and we can study around 100 fields. Okay? And the fixatives used is usually methanol or 95% ethanol. And identification of malarial parasites on thin blood films requires a systematic approach. And 3 major factors should be considered. Ito yung mga common na tinitignan natin. Siyempre, appearance of the infected erythrocytes, appearance of the parasites, and the stages found. I have already discussed kanina yung importance ito. For example, appearance of the infected erythrocytes. Is it enlarged? Is it fimbriated? Is it normal? Is it smaller than normal RBCs? Appearance of the parasites. Do we see band forms? Do we see double dot chromatin? Do we see amoeboid cells? Mga ganyan. They will help us identify what type of, what species of parasite has been seen on the peripheral blood. And syempre, stages found. Because we said a while back that not all stages of the parasites are seen in cases of Plasmodium falciparum. For example, only the gametocyte and the ring forms will be seen. Okay po. The size of the infected erythrocyte is a particularly useful feature for determining infected species. Nasabi ko na kanina. For P. vivax and P. ovale, usually they are enlarged. The cells are enlarged. But for Falciparum and Malariae, usually they are of normal in size. How do we know? We compare them to the neighboring uninfected cells. Okay? So here's an example of the thick and thin blood smear for malaria. On the left side is the thin smear, wherein we can appreciate the morphology of the cells. And for the thick smear, we see here the hemoglobinized cells. Bali, we see here just the parasites. Kaya ginagamit usually for detection and quantitation of parasitic load, ginagamit ang ating pong thick blood smear. Okay? Thick blood smear. So, species differentiation on thin films, we have already discussed this a while ago. So here's just the summary. Okay? And here's the appearance ng atin pong parasites on the thin smears. Na-discuss na rin natin kanina. And for the tick smears, usually these are many cell tick and contains around 6 to 20 times as much blood as the thin film or smear. It is preferred for detecting malaria infections because a greater quantity of blood is examined. So ring forms often have the appearance of punctuation marks rather than complete rings. Bakit po? Compared to the thin smear na yung cells natin are intact, in the tick smear, usually the cells may no longer be intact. Makikita mo lang dyan yung mga WBCs, yung mga parasites mismo, tapos yung kanilang mga chromatin dots. Kaya usually, they just appear na parang punctuation marks na lang, parang mga comma, mga period na makikita mo dyan sa smear. Okay? So, species differentiation on tick films natin, ayan, nabanggit na rin natin to kanina. We have already discussed this a while back. And that ends my part for the lecture. And for the next reporter, ito pa siya.
Another method to diagnose malarial parasite is to calculate the parasite density using the all immersion objective or all immersion lens with 100 times magnification. Now, to do that, you have to select area with 10 to 20 white blood cells per field and then count the number of asexual parasites and white blood cells in the same field. So you have to count both the asexual parasites and then the white blood cells on the same field on the thick smear. And then the count should be more than or equal to 200 white blood cells. Now assume that white blood cells is 8,000 per eye or you count it. And then to compute for the parasites per microliter, the formula is the parasite counted or the asexual parasites counted times the WBC count per microliter and divided by the WBC you have counted. Another method is to still under calculating parasite density is to count the number of parasitized and non-parasitized red blood cells in the same fields on thin smear. Now count 1,000 RBCs. Now there are fewer red blood cells if parasitemia is high. The number of parasites in 1 microliter of blood is equal to RBC in million divided by CMM times percentage of the parasite. Now next, in this table, we can see that there is parasitemia 2 to 5%. There is 2 to 5% parasitemia if the parasites per microliter is 100,000 to that should be 250,000 to 250,000. Now the remarks are hyperparasitemia or severe malaria, and there is increased mortality. Now parasitemia is 10% if the parasites per microliter is 500,000. Now, exchange transfusion may be considered and there is also high mortality. Now, there would be 0.00001 to 0.0004% parasitemia if there are 5 to 20 parasites per microliter. And the remarks is sensitivity of thick blood film. Now, parasitemia of 0.002% if there are 100 parasites per microliter. And the patients may have symptoms below this level where malaria is seasonal. Now, 0.2% parasitemia if there are 10,000 parasites per microliter. Now, the level above which immune show symptoms. So, in this percentage, nagkakaroon na or nagpapakita na ng symptoms. Now, 2% parasitemia if there are 100,000 parasites per microliter. Now, alternate method to estimate parasite density is to count the number of asexual parasites per high power field or HPF on a thick blood film, and this is how you score it. Isang plus if there are 1 positive if there are 1 to 10 parasites per 100 HPF. Plus if there are 11 to 100 parasites per 100 HPF. Plus if there are 1 to 10 parasites per each HPF or each high power field, and plus if there are more than 10 parasites per each HPF. Right, next method is another method to diagnose malarial parasite is via fluorescent microscopy. Fluorescent microscopy is a modification of light microscopy, and it detects the dyes used in fluorescent microscopy can detect RNA and DNA that is contained in the parasites. Now, nucleic material not normally in mature RBCs. Now, we have this Kawamoto technique wherein stain thin film with using the dye acridine orange. It requires centrifuge, it requires special equipment. It requires special equipment such as fluorescent microscope, of course, kasi nga fluorescent microscopy. And the nuclei of malaria parasites fluoresce bright green and the cytoplasm is red. Now, using fluorescent microscopy, the nucleus of the malaria parasite will appear as green, bright green, and then the cytoplasm will appear red. Now, staining itself is cheap, and since cheap yung simple na staining, and sensitivities of fluorescent microscopy is around 90%. Next is quantitative Buffy code. It is useful for screening large numbers of samples. It also is quick and it saves time. It requires centrifuge and other special stains. Now, the malaria parasite will fluoresce green-yellow against the dark red-black background. So, here in quantitative Buffy code, the color of your malaria parasite is green-yellow against a dark red-black background. Now, there are disadvantages for this method. First is species identification and quantification is difficult. There is high cost of capillaries and equipment, and can store capillaries for later reference. So, if you use quantitative Buffy code, you have to observe immediately because you can store the capillaries for later references. So, this is how it looks like, the quantitative Buffy code. And then as you can see, on your right, yan, the PVVAX trophocytes on the arrow, and there, itong on the left naman part, that is your Buffy code with different layers. Next method is malarial serology. Malarial serology is also known as antibody detection. This is immunologic assays to detect the host response or yung response of the host when infected by the malarial parasite. Now, antibodies to asexual parasites appear some days after invasion of RBCs and may persist for months. Now, positive test indicates if this test is positive, it means that there is already a past infection. Now, it is not useful for treatment decisions. Malarial serology is not useful for treatment decisions, and it is valuable epidemiologic tool in some settings. Now, this method is useful for the following. First, identifying infective donor in transfusion or transmitted malaria. Next is investigating congenital malaria, especially if the mom smear is negative. Diagnosing or ruling out tropical splenomegaly syndrome. And retrospective confirmation of empirically treated non-immunes. Next method under malarial serology is malarial rapid diagnostic test. Again, malarial rapid diagnostic test is under malarial serology. Now, these tests make use of immunochromatographic methods in order to detect Plasmodium-specific antigens in a finger prick blood sample. Now, antigens being targeted by rapid diagnostic test are histidine-rich protein 2 or HRP2. It is a water-soluble protein produced by the trophozoites and young gametophytes of Plasmodium falciparum. Next is Plasmodium lactate dehydrogenase or PLDH, which is produced by both the sexual and asexual stages and can distinguish between P. falciparum and non-P. falciparum, but not among the non-P. falciparum species. So, again, PLDH can distinguish between the Plasmodium falciparum and non-Plasmodium falciparum, but not among the non-falciparum species. Last antigen being targeted by RDT is the Plasmodium aldolase It is an enzyme in the parasite glycolytic pathway expressed by the blood stages of all the Plasmodium species. Now, together with HRP2 or the histidine-rich protein 2, Plasmodium aldolase has been used in combined immunochromatographic test targeting the pan-malarial antigen or PMA. So, in targeting PMA, we use both the HRP2 and then the Plasmodium aldolase. Now, these tests can be performed in 50 to 30 minutes without the use of electricity, special equipment, or any training in microscopy, and most kits have more than 90% specificity. Now, here are the RDT test formats or the kits. Ito yung makikita, the plastic cassette, card, dipstick, hybrid cassette dipsticks. Then, current RDT formats or combo tests, here are the following. You can just read it there. Now, potential applications for RDTs is diagnosis in remote areas. Of course, kasi pag sa remote areas, wala naman tayong access for mga magagandang equipment and all. And then, confirmation of dubious microscopy diagnosis, rapid outbreak investigation, and surveillance dahil nga 90% naman ang kanyang specificity and madali lang siyang gamitin. And then, laboratory-based screening and diagnosis. Next is, under your malarial serology, is the polymerase chain reaction and PCR. You all know this. It is a molecular technique to identify parasite genetic material. It uses whole blood collected in anticoagulated tube or directly onto filter paper. Now, the threshold of detection of PCR is 5 parasites per microliter. Definitive species, specific diagnosis is now possible using PCR. Now, PCR can also identify mutations, and then these mutations will be correlated to drug resistance. Now, parasitemia is not quantifiable using PCR. It may have use in epidemiologic studies. It requires specialized equipment, reagents, and of course, training for using the PCR. Other methods under malarial serology are indirect hemagglutination, indirect fluorescent antibody test, enzyme-linked immunosorbent assay or ELISA, and these three cannot differentiate between current and past infections and are therefore most helpful in epidemiology studies. Now, after the laboratory diagnosis for malarial parasite, we now proceed to the treatment. So, these are the following drugs used in single drug therapies. Pag single drug, siya lang, wala siyang ibang kasama. First is quinine. For many years, the only effective drug for chemoprophylaxis of treatment of malaria is quinine. Now, it is a DOC for treatment of resistant falciparum malaria. So, for your resistant na falciparum, Plasmodium falciparum, quinine ang ginagamit. Now, adult treatment dose is 650 mg every 8 hours for 3 to 7 or 10 days. Now, the pediatric dose is 10 to 25 mg per kilogram of child every 8 hours for the same interval for 3 to 7 or 10 days. Next drug is quinidine. The activity of quinidine is slightly superior to that of quinine, though the cardiotoxicity is somewhat more. Yes, it is slightly superior, but the cardiotoxicity is worse and or more pronounced. Quinidine is accessible when intravenous treatment is indicated. Now, the initial dose for both adults and pediatrics is 24 mg per kilogram quinidine gluconate or 18 mg per kilogram quinidine sulfate given over 2 to 4 hour period. Now, subsequent doses, if necessary, are given at the rate of 12 mg per kilogram gluconate or 9 mg per kilogram sulfate every 8 hours. Next drug. The third drug is chloroquine. These drug alter the properties of DNA or through the effects of chloroquine in raising the pH of the parasite vesicle. Suppressive therapy against all types of malaria except CRPF and resistant strains of Vivax malaria CRPV. Now, the dosage is 1 gram of chloroquine phosphate or 600 milligram chloroquine base initially. And then followed by 500 milligram or 300 milligram base 6 hours later, and a single dose of 500 milligram or 300 milligram base 300 milligram base of chloroquine on each of the 2 following days. Now, the total dose should be 1.5 gram of the base. Next is pediatric dosage. For children, the dosage is 10 milligram per kilogram chloroquine or hydrochloroquine base initially, followed by 5 milligram per kilogram in 6 hours and on each of the 2 following days. Next drug is your amodiaquine or camoquine. It is similar to chloroquine in clinical efficacy and toxicity. For clinical cure in adults, this is used for clinical cure in adults and children. Now, the same doses and interval with your chloroquine. But amodiaquine may be given during pregnancy. Next drug is your pyrimethamine or your Daraprim. Daraprim is used since resistance has been so widespread or has become so widespread. Its main use is in combination with sulfadoxine as Fansidar and with dapsone as Maloprine. Next is your mefloquine or your Lariam. It is effective against both your chloroquine sensitive and resistant strains of Plasmodium falciparum and Plasmodium vivax. Now, if your Plasmodium falciparum or your Plasmodium vivax is resistant to your chloroquine, you may use this, the mefloquine or Lariam. It is also effective against malaria and ovale. Now, for children, the weekly dose is as follows. Now, 5 to 10 kilogram, yan, 1/8 of the tablet. 11 to 20 kilogram child, you may use a quarter tablet. 21 to 30 kilogram child, a half tablet. Now, 31 to 45 kilogram person is 3/4 tablet. And then if a person has more than 45 kilogram or the child is more than 45 kilogram, you may give 1 tablet or 250 milligram. Now, the adult treatment dose is 750 milligram followed 12 hours later by 500 milligram. Now, the recommended pediatric treatment dose is 15 milligram per kilogram followed 12 hours later by 10 milligram per kilogram. So, that's for your mefloquine or Lariam. Next drug is your doxycycline. Now, doxycycline cannot be relied on to achieve radical cure. So, if gusto mo bilisan na gamutan, hindi necessary na doxycycline. Prophylactic dose of doxycycline for adults is 100 mg daily. For children older than 8 years old, it is 2 mg per kilogram, maximum of 100 mg daily. Next is your proguanil, or also commonly known as paludrin. Now, the suppressive dose for adults is 200 mg daily, continued for 4 weeks after leaving the malarious area. Now, some authorities recommend adding a weekly dose of chloroquine at the usual levels. Now, to children, you may give this as follows. So, if the child is less than 2 years old, you may use 50 milligram daily. Now, for 2 to 6 years old child, you may use 100 milligram daily. And for 7 to 10 years old child, 150 milligram daily. Now, if the child is more than 10 years old, you may use 200 milligram daily. Next drug Yan, marami-rami to. The next, halofantrine or halfan. It is effective in the treatment of multi-drug resistant Plasmodium falciparum at doses similar to those used with mefloquine. And the recommended dosage for halofantrine, yan, is 8 mg per kilogram, repeated after 6 to 12 hours. And in non-immune patients, a further 3 daily doses 1 week later. Next drug, artemisinin. It is effective for both your Plasmodium falciparum and Plasmodium vivax and several derivatives, including, among others, the artemether and sodium artesunate seem to be even more active, especially in patients with cerebral malaria. Now, if your patients ay nagkaroon na ng cerebral malaria, then you can use this drug. Its chief value will be its use in combination with other anti-malarials. Let's proceed. The next drug is norfloxacin or ciprofloxacin. Now, these fluoroquinone antibacterial agents were found to be effective in vitro against CRPF. However, both were shown to be ineffective in clinical trials. Now, a while ago, we talked about the single drug therapy. Let's now proceed with the multiple drug prophylaxis and treatment of resistant falciparum malaria. The first multiple drug combination is your pyrimethamine sulfadoxine or Fansidar. It is a combination of 25 mg pyrimethamine with 500 mg sulfadoxine or Fansidar. And it is widely used for prophylaxis of CRPF. Now, the adult dose is 3 tablets taken as a single dose for adults. Now, for children, the dose is as follows. Again, you can just check it. This is according to the weight of the child. Next, yeah. Let's proceed with the treatment of tissue schizons and hypnozoites and gametocytes. First is your primaquine. Primaquine is effective against the hypnozoites of Plasmodium vivax and probably your Plasmodium ovale, and is gametocyticidal for all 4 species of malaria. So, gametocyte pa lang namamatay na. Adult dose is 30 mg primaquine base daily for 14 days. Now, the dose for children is 0.6 mg per kilogram of the base daily, also for 14 days. So those are your drugs, or those can be your treatment for your Plasmodium or malarial parasites. Now, aside from before going to the treatment, also we should know the prevention muna. So, malaria can often be avoided using the ABCD approach to prevention, which stands for A is awareness of risk, B, bite prevention, C, check whether you need to take malaria prevention tablets, and D, diagnosis. So, first is awareness of risk. To find out whether you're at risk of getting malaria, you have to check the area, your environment, yung mga ganon. Now, bite prevention, avoid mosquito bites by using insect repellent, covering your arms and your legs, and using a mosquito net. And of course, syempre, bite prevention, paglilinis din yan ng ating paligid, of course. Now, check whether you need to take malaria prevention tablets. If you do need to take malaria prevention tablets, make sure you take the right anti-malarial tablets at the right dose and at the right course. Or you have to finish the course or the days kung kailan mo siya or hanggang kailan mo siya dapat i-take for you to avoid having resistant strains. Lastly is diagnosis. Seek immediate medical advice if you have malarial symptoms. So, yung mga following symptoms naman ay nabanggit kanina, including up to a year after your return from traveling. So, these are our references, some of our references. Thank you so much. Again, here's our group. Thank you for listening.
don't feel as small